Let's move on to the next session. That is, before introducing formally, I would like to say Madam has conducted so many programs organized in the JIPMER, starting from NTTC to RBCW, CISP, and many more. It's my great privilege to introduce Dr. Kadambari. Dr. Kadambari D is an expert in medical education who was the coordinator of curriculum reform from MBBS course in the JIPMER, and Madam is Professor of Surgery JIPMER, and Madam has completed the FEMA, that is Kelly Masters in Health and Professions Education, and has awarded the MHPE in Assessment and Accreditation. Coming to the parent department, Madam started Madam joined the General Surgery Department of JIPMER as a senior resident and worked there to different capacities, starting from assistant professor to professor and HOD. She also headed the Department of Medical Education from 2016 to 2019. Madam's areas of interest are mainly breast oncology and breast surgery, and contributed and conducted many awareness programs in the field of oncology for public. And Madam is a core member of this resource person of this NTTC, prestigious NTTC JIPMER, and recipient of UICC Technical Fellowship in Oncologic Breast Surgery in the University Hospital Great James Paget University, UK in the year 2018, and membership of many national and international societies like International Surgical Society, Breast Surgery International, Association of Surgeons of India, Association of Breast Surgeons of India, Association of Medical Education of Europe, and around 51 scientific papers are there to Madam's credit, and I think many book chapters are there, and I have come across one book that is Improving Discipline-Based Undergraduate Medical Curriculum. That is one of the best, I think. So welcome you, ma'am, for this. And
thank you for that very kind introduction. So when Dr. Mahalakshmi called me about talking on a topic, I had just read a paper. We just had a session on mentorship. So I had just read a paper which was published, which is being published by my mentor, whom I consider one of my mentors, Professor Janet Grant. And she had written this paper, which is going to come out in the journal Medical Education in the coming issues. She talked about knowledge and contextuality. And that is her mantra, which she constantly keeps reminding me that when we look at education, we should not forget context, the context in which it is happening. So I thought this will be a good forum for me to pass on that idea, because it synchronizes with the way I think as well. So that's why I chose the topic, and since this is on medical education, I wanted to choose the topic of educational research, because that is one area where we are lacking in this country. So, why is it going off? This is the next button. This one. Okay. Sorry. It's not working.
This one. This one.
This one. Okay. Sorry. It doesn't work. Okay. So I'm going to answer a few questions which I think will kind of make the topic clear to you. So first, I will try to discuss what we mean by evidence in education, why we need evidence in education, and where do we look for this evidence, what are the sources of evidence, what is research and what is evaluation, What do we mean by the term context? Why contextualization is important for educational research? I will give an example of curriculum development to answer this, make this concept a little more clear. We'll look a little bit at what is happening in India in the field of medical education research. And finally, some ideas for moving forward in this field. So what do we mean by evidence? We all do biomedical research, right? We are collecting data, we are providing evidence for improving our patient outcomes. So generally evidence, as all of us who have gone through research methodology courses, depends upon the research question. What are we trying to ask here? So are we looking at the direct impact of our intervention? Are we looking at how the intervention is working? Are we looking at, for example, what is the nature of a problem? If you have a problem, for example, of absenteeism, why is it happening in certain courses, in certain levels of students? How a naturally occurring process is taking place? How is learning occurring? So the evidence that we seek depends upon the question we ask, and that will also influence the methodology that we choose. So why do we need this evidence? There is a lot of talk about evidence-based practice, and we are gathering evidence to improve our practice. It's the same in education as well. This, in fact, the field of education has drawn this concept of evidence-based practice from medicine. So it is used to inform educational policy, to inform educational practice, to improve the quality. Based on our evidence, we can improve or implement quality improvement measures. Importantly, to understand phenomena, ask the question why, which is a very important thing in educational research. For example, you have an intervention, okay? You introduce small group teaching in and you compare two groups or whatever, you do an experiment. It may tell you that it has no difference between the two groups. It worked in one group, it didn't work in the other group, or the results were the same. But why? Why is there a difference? What is explaining that difference? That is what I meant by that. To explain why an intervention works. So there are two broad areas from which we derive this evidence. One is research. Generally, the focus of research is to create knowledge and to use that knowledge in other contexts or other situations as well. Evaluation, on the other hand, is also a type of research, but its focus is on trying to look at the value of a practice. You have program evaluation, right? You implement a training course, you do an evaluation of that program to see how effective it was, whether it achieved its outcomes. So for the purpose of this talk, I'm not going to talk about evaluation, it's an entirely different topic. I just wanted to differentiate this because many times research and evaluation are used interchangeably, but there is a slight difference between the two. So just to point out where we differ in our routine biomedical research, whether it's in the basic or clinical sciences, and how it differs from educational research. Basically, in biomedical sciences, causality is a major thrust, right? And generalizability. If we find results in one context, we want to replicate it in another context, or we believe that those results are applicable in our context. And context is seen as noise. So generally, context is stripped away from the analysis. They do not take into consideration the context most of the time. So you have strict control. When you have randomized control trials, you have strict control of your inclusion of your participants. So that is where the context is removed. And patient outcomes are the primary concern in biomedical research. In educational research, what we are trying to do is understand and interpret. Therefore, findings are context specific because you are asking the question why. So why can be explained only if you take the context into consideration. And although we think that Kirkpatrick's level 4 is the ultimate level at which we have to judge our intervention, I would beg to disagree, because looking at patient outcomes as an outcome of your educational intervention is very far-fetched. What you do in the first year may not, there are a lot of intervening factors which can impact on patient outcomes later on. So it's not always necessary to look at Kirkpatrick's level 4. So what we need to see is what change it is bringing about in the learner, behavior, knowledge, attitude, and so on. So the learner is the primary customer of educational research. So with that background, I'll come to the concept of context. Basically, context has been described in a very artistic way as the fertile soil in which many interventions can flower. Right? So context is the thing, the situation, you can call it the situation, it's the surrounding, it can be described as an environment in which your intervention is taking place, and therefore that is determining whether your intervention is going to work or not. So for example, I have tried to take an analogy in our regular medical practice, history taking, right? We teach our students, take the socio-demographic history, personal history, and cultural history, and so on. So all these are important aspects which will help them to make a diagnosis, which influence their decision to make a diagnosis, right? So that is what context means. Now look at this figure. Quickly tell me which orange ball is bigger? The one on the right or the left? The one on the right. Actually, both are the same size. Okay? So this is what is known as Ebbinger's illusion, and this gives a very pictorial way of explaining what is the effect of context. Right? The other side looks bigger because the surrounding circles are smaller. So that is the context. So context has an influence on perception and interpretation. And that is why it is so important, particularly in social science research like education. Education is a social science research. And therefore, context of the phenomenon, social and cultural context, have a significant role to play in explaining the causal mechanism. So, as we have seen, or as you might have gathered by now, context is a fuzzy concept. Okay, it's very difficult to define concept. So, what we can look at is to explain what context is, to look at some of the factors which. Before we go to that, why does study of context impact? How does it impact and why is it important? First thing, it explains the difference, the variations in the outcome of your intervention. Why it worked in one place, why it did not work in another place. It explains differences in causal mechanisms. What explains the difference in two locations. It facilitates success of if you understand the context where you are implementing a quality improvement initiative, then it becomes easier for you to tune your quality improvement initiative to match the context. And finally, context also shapes cognition. Our students learn based on the influence of their cultural background, their socio-economic background, their parental background, the college in which they are studying, the location, the geographic area. There are so many factors which shape their learning, and that is the term which is used here, context dependency of learning. So this is just to reiterate that the focus of context here is as important as the content and the process. What you are doing, how you are doing it, important to also look at where you are doing your intervention, right? So what we need to consider as context in educational research are at two levels, the micro level and the macro level. The macro level includes socio-cultural, political. Political I don't mean by BJP or Congress. Political is like what Dr. Mahalakshmi just referred to, the local environment, right? And the healthcare system, that has a significant effect on any educational intervention that you are going to implement. And at the micro level, the organization, what kind of a setup is it? What kind of leadership is there? How supportive is it? Is it hierarchical? Similarly, in the department, you want to do something, your head of the department says, I don't have staff. You want to do, for example, introduce small group teaching where you need multiple resource persons. So you're constrained by your environment. So these are things that you need to consider. So I looked for a more clear definition of context, and I found this which kind of puts together all the aspects of context that we need to look at in medical education research. So they list patients, the kind of patients who come to your hospital which the student is exposed to, the location, is it rural, is it urban, is it western, is it oriental, the practice, the kind of practice, the disciplines that are available, is it tertiary level care, is it primary level care, community oriented, the education, the kind of education that you are, is it the type, is it problem based learning, the type of curriculum that you are using, and the society, the societal or the cultural environment. And mind you, all these factors are constantly interacting with each other and affecting each other. So it's a very dynamic kind of a situation which you need to consider. So coming to medical education research, what are the contextual factors? One is the setting of the study, which I've already referred to. The scope of practice, that is, which are you doing it in a clinical discipline? Are you doing your research in a basic science discipline or public health, allied health? What is the educational activity you're looking at? Is it curriculum design or studies where the context the contextual factors will be different? Are you looking at a teaching learning intervention where the context you have to consider will be a little different, or assessment and so on? The student factors, they are the participants of your research. So they definitely bring in their own personal factors, their interaction or relationship with their peers and the patients whom they are exposed to, and the local cultural factors of the research participant, of the organization, and the societal culture. So all these have to be considered when you are designing your intervention or your study or assessing its impact. Now, till now I was talking about the term context, right? And why we need to consider context as an important factor when we do educational research. Now I'm using the term here contextualizing, which means you do your educational research in your context, right? So this is very important because, as is said in the first quotation, because educational contexts are very complex settings, right? It's not a straightforward thing. There are no linear relationships. There are many surprising events which can come in, which you cannot really explain logically. They are unique. Each educational, Dr. Mahalakshmi herself mentioned, what JIPMER is may be different from what another college is, a state college versus a central college, a government versus private. There are so many, a north versus west, a remote versus urban. There are so many differences, and it's a very complex setting. So simply transferring what has worked in another setting to your own setting and expecting it to be a simple replication is, I would say, bordering on foolish, right? You cannot expect, for example, something that has worked in JIPMER to work in even CMC for that matter. It may not, because the situation is very different. And the second one which I would appeal to me is that the best answer for a particular student in a specific context may be the worst answer for a different student in a different context, right? So this is the need for doing contextual medical research or contextualizing educational research. So I'm taking the example of curriculum development or curriculum studies to make this more clear. And again, this was a chapter which was written by Dr. Janet Grant and Anand Zakaria from CMC in the Oxford Textbook of Medical Education, where they have described what is known as a contextual curriculum. And look at all the factors which are playing a role in the design of the curriculum. So many contextual factors which we need to take into consideration. So maybe I am treading on dangerous ground here, but I would like to say that adopting the CBME from North America to India is probably not the wisest thing to do. We don't know if it works. We are simply trying to replicate. We don't even know if it's working there. There is no evidence. There has been no evaluation. And we have adopted it here without taking into consideration all the contextual factors which should be driving our own curriculum development. Okay, so that's for you to think about. So how can we go about looking at this context? This list is not exhaustive. These are some of my thoughts on the way we can look at context or study context in the area of curriculum development. We do ethnographic research. We live in the community. We look at how students think, act, what they believe in by living with them, right? Or we do the same with teachers. We do the same with other allied health professions. So we can look at ethnographic research on the nature and processes of health profession. We sit in a series of classes, observe the kind of interaction that is going on, what is helping, what is not helping, and so on, right? You can do comparative case studies. This is a ripe situation. We have implemented CBME here. CBME is going on in North America. We do a comparative case study. See what problems we are facing, why it is not a good fit, why it is a good fit in our context, and what is happening elsewhere. We can do qualitative studies and ethnographic studies and look at the way curriculum practice is shaped by social forces. And another important area where we can look at context is collaborative inquiry. That is, you don't treat participants as subjects, right? They are co-investigators. You involve them in your research. So this is a paper which I recently came across, written by Professor Dr. Amol Dongre and Dr. Deshmukh. And they have reviewed all the papers from India which were cited in PubMed. And these were their main findings. They found that there is an increase in publications over the last 8 or 10 years. Most of them were on workshop or program evaluations and surveys among stakeholders and innovations in teaching and learning methods. Most of them were quantitative, most of them were from undergraduate education, and most of them were from some departments in the institution. So we have a lot of barriers, right? It's still a budding field in the country. There are lots of barriers which we have to overcome before we can establish our own database, the Indian database of evidence based on which we can develop our own educational policies. So these are some of the constraints which we need to overcome. So how do we move forward? One way is do other methods. The RCT is not the answer to looking at educational research. It is not the ideal way of studying educational research. Do more qualitative studies. Do mixed method studies which look at both quantitative and qualitative. They give you a measurement and quantification as well as an explanation or an understanding. We need to look more at general education research. Ensure rigor in methodology. Develop your scholarship in educational research. Test theory before you implement it or to see whether it works, right? For example, topics like self-assessment. Test the theory and see there is actually what is the theory of self, right? Whether it applies in medical education. And involve the stakeholders more into your research. So as far as the organization goes, we need to have a learning organization where medical education is supported and nourished, and create a learning environment where we look more at innovation rather than replication. So simply not reproducing things which are done elsewhere, but doing our own innovations. So I will end my presentation with a few take-home points. Our firm knowledge of the educational process is very limited. Okay, so we have to accept that. It is unrealistic for social science or educational researchers to ignore the context of studies. Social sciences differ from physical sciences in that the validity of research depends significantly on the context. The research design is not complete without specification of the context in which it will be conducted and the context where the findings may be reasonably useful. Ethical communication. When we publish our research, we should not hide the context. We have to disclose it. Okay? Then the reader will be able to judge whether they can implement or take back what you are saying is a good way of doing things. And develop the theory and then test the theory in different contexts. That would be a better way of going about it rather than simply trying to implement what is done elsewhere. Okay, so thank you for the opportunity, and I thank Dr. Mahalakshmi for giving me this chance to share my thoughts, and I'm particularly grateful to Dr. Janet Grant for stimulating my way of thinking in this field. Thank you very much. I'll be happy to take questions.
Thank you so much, ma'am, for this inspirational, and that is a very new concept of this contextualization of medical research, medical education and research. And context, why we need to consider this context and definition of context in medical education research and factors, what are the relevant to medical education research. You explained very nicely. Thank you so much for that. Now it is open for discussion. Any questions from the audience?
Not a question, but a comment. I think this talk took a lot of courage and candor. And if I had a hat, I would doff it off to you. Very well presented, very clear as to why you think we need to figure out what works for us in our context than taking it out of a Western way of life. Ma'am, to people who are just beginning, like I am, I think it's very inspirational. Thank you.
Thank you. I wanted to share one more idea which I came across. There is a book, Medical Education for the Future, and in that they have brought in this idea of what they call neo-colonialism. So imposing, though the colonies have been, people have left, the British have left India, But still, their thoughts, they have left behind their thoughts and ideas on us, and they are still, are we still allowing them to dictate what we do? So that is a term which is, and this was raised by a British educator. Yes.
Thank you, ma'am, for that very interesting talk. And so I have a basic question. Like you said, there's neo-colonialism, and we see more and more centralization of education in India, especially medical education. And like you said, we have 600 medical colleges all over India and very, very different contexts. So how do we go about this whole process of contextualizing the curriculum for these 600 medical colleges in a practical manner? At the same time, sort of ensuring that there are certain basic standards that are met throughout the country. So I would like your thoughts on that, please, ma'am.
I think you have given the answer yourself. So you have basic things which are common across the country, okay? There may be regional differences. For example, language. Culturally, we have a lot of commonalities. So the way our students think, our basic educational system in school is similar across the country. So what we need to look at more is the location of the college. Is it urban? Is it a tertiary care center? Is it rural? Is it remote? There things may be a little different. And there probably, for example, you have a curriculum where you have to have, just the same example which I cited before. Please sit down. You talked about small group teaching as one of the innovations in your talk yesterday. So is it feasible in all colleges or in departments where you have only 2 or 3 faculty? Many private colleges have that. So you are imposing something on them saying this works. In theory, it has worked in the West where things are very different, or it may work in JIPMER where we have many faculty to implement that intervention. So all interventions or all methods. So people should not go back thinking small group teaching is the ideal way of doing things, and my college is lacking in it because I don't have the facility and therefore I am behind. No. He or she, the teacher, has to innovate. What would be the best alternative to small group teaching given my constraints? That is where innovation comes in. That's where contextualization is. So you can have a general base of curriculum, and curriculum, as you know, is not syllabus, right? It's not equivalent to syllabus. It's a more dynamic thing than that. Takes a lot of things into consideration. So therefore, that way curriculum can be contextualized.
Thank you.
Does that answer your question?
Thank you.
Okay.
Thank you for that excellent talk, and I think this just underlines what we have believed for a long time in simulation as well, in that some of the solutions that are provided to us from the developed countries need not necessarily work in our context. And I think one of the very important aspects that we need to study in education is culture. You know, most of the differences that we have from there and here ultimately stems from cultural background that our culture is different.
Correct.
And in fact, we are now working currently on a paper from many countries. We are working together to look at how culture is influencing delivery of simulation education. And I think that's something that also is important to consider in context in addition to geographical differences.
Absolutely. Cross-cultural studies, there is a discipline, cross-cultural psychology. So there definitely is an influence of culture, yes.
Ma'am, thank you for accepting our this thing and delivering this talk. Anyway, you know me for the last 25 years, you know that I throw tantrums. So Madam accommodates whatever I ask for. Actually, this is in taking with what Dr. Nachiket was talking about. How do we contextualize the CBMA curriculum? You said that we are trying to ape. But the thing is, where we have gone wrong, like if I am allowed to say this in this forum, is like we are not told anatomy to work out how you are going to inculcate IMG from your principles. We should have given it to them. This is what we want from IMG, the 5 roles. How you are going to teach that in anatomy? Then it would have been much better. Where we ended up is we wrote some kind of objective bar competency, bar sub competencies, and some new norm has come, right?
Yes.
I don't know what, something one new name also has come. So we are trying to be very, very prescriptive and say that you have to teach this in small group, you have to assess it in this fashion, and this is a core thing. So when it became like that, when you try to make it very rigid, that is where actually people they get the terminologies. There are a lot of jargon people have picked up without really understanding what is the
Exactly.
context or what is the principle behind CBME in which it has been implemented. So that is, I think, something which we need to really ask. How is this IMG getting addressed in that 412 in anatomy or in 120 which is there in community medicine? I think that's where we need to work as a team context.
So those are the very, what you call, shall I say, focused areas in the curriculum. On a broad level itself, what was wrong with our traditional curriculum? Did we look into it? Did we really study it? Did we evaluate it? Did we see where it was going wrong? In many instances, knowledge in education is socially constructed. Okay, I talk to my colleagues, I feel that, students are losing their values as they move from first year to final year. That's my impression. I have had so many generations of students. My colleague also feels the same way, right? So that may be an area where we can look into. Why is this happening? What is the reason by which, and why is it happening to our Indian students? Is it really happening, and why is it happening? So did we evaluate in a similar manner our traditional curriculum? It was all, they are not doing this, they are not integrating, they are not able to answer questions. Did we look at our assessment system? Did we look at our teaching learning? Why did we adopt a new curriculum without evaluating an old curriculum? Even the roles, the so-called roles of the IMG are borrowed from the CAN meds. Why can't we have our own set of roles based on what our health needs are, what our health system is, what our patients need from doctors? That should have been the basis of curriculum design, and that's what is contextual curriculum. So we as medical educators should not, we are teachers, we are the ones who are ultimately delivering the curriculum. And I'm not asking you to, rise in an uprising or anything like that, but we need to question. We need to really look into our practices, evaluate them, keep innovating. And curriculum is not a static document, right? It is a live thing. So you can keep on modifying your curriculum according to your innovations. Okay, thank you very much. It was
No more questions. Thank you, ma'am. We'll conclude this.
Thank you, ma'am. Now I request Dr. Sashmita Mishra, our chairperson, to present the memento to the resource person, Dr. D. Kadambari, Professor of Surgery, JIPMER, Puducherry. Now I request Dr. Dinkar Pai, Director Medical Simulation Center, MGMCRI, Puducherry, to present the mementos to our chairpersons. Chairperson Dr. L. Rajan, Professor and HOD, Department of Anesthesia, Arpadavidam Medical College. To Dr. R. Lata, Professor and HOD, Department of Microbiology, Arpadavidam Medical College. Dr. Sashmita Mishra, Professor, Department of Biochemistry, Arpadavidam Medical College. Thank you, sir. Now we'll request all the delegates to join us for the high tea and snacks which is served outside. Meanwhile, I have one small